Hey, good afternoon, everyone. Welcome. I am Catherine Brookman, Associate Director of Knowledge Transfer and Exchange, and on behalf of Dr. Jack Callahan, Director of the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD as we are more commonly known, along with Public Services Health and Safety Association, our collaborator, we'd like to thank you for joining us today for this free webinar with our Client Patient Handling Community of Practice. We are grateful to the Ministry of Labor, Training and Skills Development for our funding, which supports the delivery of these webinars, and of course to our presenters who provide their expertise. The format of today's webinar is as follows. The presentation will be given, after which time we will have 10 to 15 minutes for your questions. We ask that you type your questions into the chat box, and I will relay these questions or their themes, should there be duplications, back and forth to the presenters. Should you have a pressing question that cannot wait until the end of the webinar, such as a technology glitch, please type this into the chat box and we will do our best to address it right away. We will be providing you with a copy of the presentation shortly after the webinar, along with an evaluation that we encourage you to complete to assist us in the future delivery and planning of our webinars. The presentation will be recorded, and this and the PowerPoint presentation will be made available to you on the CRE-MSD events page over the next few weeks. In the interest of time, I am not going to formally introduce my two co-presenters. However, I would encourage you to review our biographies that are posted on the CRE-MSD events page under today's webinar. Finally, just before we begin, for those of you who are joining your colleagues today and who haven't registered, just let us know if you could type in the chat box how many people are joining you so we could have an accurate record of all of the attendees today. So without further ado, I'm pleased to bring you a multidisciplinary analysis of assisted sit-to-stand techniques, a work in progress. We're going to cover today our background and approach, our core assumptions, the analysis of techniques, getting to edge sitting, and standing up. Assisting with sit-to-stand is a common activity of personal support workers. If not done properly, both the client and the caregiver are at risk of injury. Client handling accounts for approximately 50% of caregivers' work-related lost time injuries. Proper training of personal support workers is critical to preventing these type of injuries and improving client satisfaction and well-being. There is no standardized training for personal support workers either through formal education or through employer in services. Community of practice members have reported that they have a lack of confidence in the effectiveness of their existing training resources. They also reported a need for an evidence-based tool to assist them in improving the training of their personal support workers in client-patient handling. Therefore, on behalf of the community of practice, the three of us, Sheila, Emily, and I, put forward a seed grant to develop a framework for evaluating PSW sit-to-stand and stand-to-sit training. We held a webinar on this in July of 2019 to elicit more feedback, and today we are presenting to you the multidisciplinary analysis of assisted sit-to-stand techniques. We collected material from across the community of practice membership and did a descriptive analysis of these training materials. We also held two multidisciplinary panel workshops, and as I mentioned, presented to you a webinar in July on our framework suggested draft findings, and today, of course, the webinar. Just would like to bring your attention before we launch into the core content that the approach we are presenting today works in 10 major handling tasks. And while I won't go through the 10 of them, I do encourage you to look back on them once you get the slide deck. So I'm now going to call upon my co-presenter, Dr. Sheila Ritcey, to talk to you about the care philosophy, restorative care.
Thank you, Catherine, and welcome everyone to this webinar. I'm Sheila Ritcey, and I'm going to take you through the next few slides. We're going to look at the care philosophy that was used in this framework and look at some of the approaches that were identified for the sit-to-stand task. Sitting to standing is considered one of the most important tasks that we require to maintain independence and quality of life. So first, we're going to look at the approach, and then we're going to review the approaches that are accepted as best practice. Then we'll also examine approaches that were identified as still in use but raised some concerns. The restorative approach focuses on supporting clients to achieve their optimal function with the lowest level possible of ongoing support. It's very well known in a lot of other countries like Australia, New Zealand, the UK, the Scandinavian countries, and is certainly now introduced into Canada. I put a little attention here to positive risk taking because taking risks is a normal part of everyday living. The dignity of risk is enshrined in our Human Rights Code and protects our rights to self-determination and choice. When we can't do things that are important to us, it has a big impact on our sense of well-being, our sense of self, and is not considered useful in a reablement model. Protectionism and risk aversion do not promote an active or fulfilling lifestyle. So it's integral to a restorative approach that positive risk taking is respected and acknowledged. The health benefits of a reablement or restorative approach are wonderful. They help the client to the greatest extent in their own mobility and daily activities. And we're talking, when we talk about daily activities, not activities of daily living, but much more focus on what's described as experiential life. What do people do in their day's activities that are important to them? So this approach promotes maintenance and restoration of function. It improves self-rated health, it improves confidence and well-being, and obviously it decreases the need for ongoing care. Why do we use it? It's a good, very good for the client. It helps clients to engage independently in everyday living and social activities. Big emphasis on the community in this approach. PSW assistance supports the rehabilitation goals. It also improves client satisfaction and well-being. It's good for the caregiver. Obviously, it reduces risk of injury when the client is participating more fully in each activity. And it again has been shown to improve caregiver satisfaction and well-being. When they see clients improving and taking back functioning that they have not been performing, it's a very positive effect for the caregiver. The alternative, doing things to or for rather than with the client, is a big focus of this approach, of doing things with the client as opposed to the to and for. If we use the old model, we encourage a passive role and deconditioning. We get loss of client confidence, skills, and belief in personal abilities. We assume when we're doing a task like sit to stand that there has been a transfer assessment, probably by an occupational therapist or a PT. And it's very important because in the care plan, there will be clear direction about what sort of transfer should be used. I'm going to remind people that in a reablement model, they talk about a support plan as opposed to a care plan. They give a much more active role to the client here. The other status that is very important when we're doing this kind of task is to understand the weight bearing status for the client. So again, these are caveats that you would not be standing someone if you did not know their weight bearing status. If none of the recommended techniques are sufficient to assist the client, then I guess we're moving into the assistive equipment, which might be required. And again, we need to balance the use of equipment with the use of transfers, because transfers are considered therapeutic activities. They involve active participation by the client. When we move to a lift, we're moving into situations which can certainly contribute to deconditioning. So, what are the factors that we assess for each technique? And this was very interesting to get feedback from the contributors to this study. What are the advantages of the technique being used? Why did you pick it? Why are you using it? How does it contribute to building clients' confidence, skills, and independence? And the other important factor, which I think sometimes we don't pay as much attention to as we should, is ways in which it reinforces dependence. Is the technique we're doing actually actively reinforcing dependence in the client? Then we looked at risk to the client and obviously risk to the caregiver. And the last category factor that we assessed was necessary client ability. Does the client have the person abilities to perform the task we're asking them to do, and the space involved, the environmental issues that anyone who works especially in the community, is faced with: very small washrooms, beds rammed against the wall where we can't access the person that we're supposed to be assisting. So very important to look at: does the client have the abilities to do what you're asking them to do, and are the environmental issues being addressed properly? We're going to move on to the analysis of the techniques that we looked at. And getting to edge sitting is one, and then the actually standing up. Edge sitting, which our gentleman is doing here, is the optimal start position. Each of those 10 tasks that Catherine referred to earlier has an optimal start position, and that is very important that people respect that optimal start position and ensure that their client is in the best position possible to have success in the tasks that we've asked them to do. How do we get that person to edge sitting? And we looked at the ways people do this, and in all these techniques that we're looking at what is recommended in best practice, and what we do, but would be considered somewhat controversial. The independent shift or shimmy to get to edge sitting was something that we examined. And then the assisted shimmy. How do we help someone who has a real problem with getting into that edge sitting position? What are the ways that we can help them? So the independent shimmy is not depicted here. I'm just going to, and I don't need to remind you because you all do this. I think the ability to take the weight off one buttock and shift the buttock forward, and then switch to the other side, take the weight off the opposite buttock, and move to the edge of the chair is something that we might just talk to a person about. The assisted shimmy is a way that we can help that person who cannot make that move independently. And what you see here is a kneeling position. The caregiver is down on one knee. They've got one hand on the hip of the buttock that we're raising off the chair, and the other hand on the person's shin. So we can then use leverage to help shift that one side forward and then switch to the other side, and the caregiver is going to change their position to the other knee. So the advantages of this, the client is participating in the activity, they're increasing their ability to move, to hopefully to edge sit independently, and the caregiver can use leverage. They're using their body weight to lean backwards and help shift that one hip forward. The disadvantages identified here where the caregiver is still providing substantial assistance. So in that way, they're contributing to some dependence. The risks, well, there's obviously a potential for skin shearing, but there's minimal risk to the caregiver. Our contributors identified for a slouch approach was the client actually is acting independently, and that may increase their confidence. So as you can see, our gentleman has slouched forward. So he is moving to the front of the chair, but obviously his head and shoulders, his top torso are leaning backwards into the chair. There is some risk to the caregiver in the potential if the caregiver tries to help that person move from that slouch position into an upright posture, that could pose some risks for them. There's the risk of skin shearing. When we're sliding along the chair, that could cause some issues. There's also the risk of falling. If you slouch forward in a chair like that, you can consider that some of your clients might slide right off onto the floor. So if we move to the next slide, it's getting the red not recommended, that is not considered best practice because of the risk to the client and because it does not use normal movement patterns. We're recommending the independent or assisted shimmy. So those preceding slides have looked at getting the person into the optimal start position, which is edge sitting. You do not hopefully ask people to stand up when they're chair sitting or they're sitting with their back right against the back of the chair. So standing up is the next step once we have hopefully our clients in edge sitting. And we're going to look at 4 variants of techniques that can be used. And then we're going to look at adaptations for difficult spaces, because one of the real issues of working in the community is the fact that you work in very cramped spaces. And then we're going to move on, and Emily will be looking at controversial techniques and some of the alternatives that can be used. So let's move on to standing. And this is just a supervised sit to stand technique. And that's basically the one where you're standing and the person can do it independently. You're supervising and you may be giving a few instructions. This client is sitting well forward. He has his hands on his sides just above his knees, which is one process that we are strongly enforcing. Most chairs that people are in aren't properly built. To put the hands on the armrest would put him in an abnormal position to try to use normal movement to stand up. If I look at him, he's got his feet flat on the floor. I'm presuming they're about 30 centimeters apart. I'm presuming, I can't see clearly that he has good footwear, but it looks like good footwear. His head, the positions of people's heads and their chins, we consider so important. His chin isn't up, it isn't down. He's controlling that cervical curve in his neck because his chin is parallel to the ground. So the advantages for this supervised approach is it reinforces optimum independent function and confidence in the client. You just might be giving a little clue that your head, you should be bending from the waist and moving a little bit forward so that we use the term nose to toes, that his nose is now over his toes. The risks are very minimal, so to either the client or the caregiver. This is a very independent way that the person can now move and just might need a little reminder or a little coaching. The minimum assisted stand, the caregiver has one hand, probably with a touch prompt at the midline, at the mid position of that person's back. It could be at shoulder level, it could be lower, depending on the height of the client. They are in a walking stance, so they can use leverage, and they're very well positioned if that client got into any trouble to assist that client. The advantages of this minimum assist: easy to adjust the level of assistance. It encourages the client to perform the majority of the transfer. The disadvantages of this we identified with the supporting client at the hand. If you're using a hand, this provider has a hand on the shoulder, but you can give a hand-to-hand support. If you do that, their arm is not free to push on their thighs or their armrests. The risks here are minimal to the client and the caregiver. Okay, now we're looking at a higher level of assistance in the sit-to-stand technique. So the advantages, as you can see, this caregiver has her forearm across the back of the client and is grasping the far hip. The advantages of this: there's a moderate client participation in the transfer. They are getting more support, but they certainly are participating. This contributes to maintaining strength and physical function. The disadvantages, again, there's increased reinforcement of dependence because you're giving increasing support from the caregiver. So we're kind of moving in the wrong direction. We would want to be moving to minimum assist, supervised assist, and then totally independent. The risks, again, are minimal in this technique to both the client and the caregiver. The last variant that we can use here is to use two caregivers. Obviously, a lot more support for the client, but the advantage is the client is still participating in the transfer, though at a lower level. There's some maintenance of strength and physical function because they are actually doing the movement. They're building core strength and obviously using their quads, etc. The disadvantage: there's moderate reinforcement. We're increasing our reinforcement of dependence by helping with the activity, increasing support. The risks, again, are minimal. If you notice the caregivers who are helping, they are in a walking stance. We're very interested in their use of leverage. We're interested in the caregiver's posture. They are positioned well to give assistance if there is a problem. So we're going to look at one of the major issues of chair options. Moving to the side, moving in the chair is that we can't reach people, and this is I'm just going to remind you that what we looked at for sitting and standing were four variants. One, just supervised. We're just there to coach a little bit. Minimal assist, which was a touch prompt. Higher level of assistance, which was using the forearm, and then the maximum support was using the forearm. Another issue that I just want to remind you is I think moved to some decisions about where the hands go when people are pushing for a sit to stand, and found that the thighs was certainly the best option for people, because you take your thighs everywhere. If you've gone out to dinner or something, your thighs are there. You're not relying on chairs. The other issue that certainly became very important to us was the instructions for standing. Instead of using 1, 2, 3, stand on 3, we found that the ready, steady, stand, which is used globally and certainly used in the UK, That kind of instruction is very good for the client because the last word tells them exactly what you want them to do. So those were two issues that became very important. I think the third issue that to me emerged as very important is you don't ask people to stand unless they're in the optimal start position. Very important that they're in that start position. So now I'm going to hand you over to my colleague, Emily, who's going to move you on to the next stage.
All right, so what do you do when you can't stand beside somebody to assist them using any of the techniques that we've been talking about? The first option that we're presenting is you help them to get to a position where you will be able to stand beside them. So we've got the example of, assisting somebody off the toilet. There is often just not room to stand beside them. But using that assisted shimmy technique that Sheila introduced, we can assist them to shimmy not just to the edge of the chair, but also to an angled position where there's some space for the caregiver now at the side. And so this allows the client to still participate in the transfer, minimizes any reinforcement of dependence. And so, of course, this is contributing to the maintenance of physical strength and function. There may be mild risks of skin shearing depending on how the shimmying is done, but the risk really to the client and caregiver remain minimal. So this is one of our recommended techniques. Next up is option 2, the front access technique. So in this case, if you really can't find any space to stand beside somebody to assist them up, this is an option that allows you to stand in front of somebody while assisting them to stand. What we have shown in these images is that the caregiver is in a walking stance, but will be rocking backwards as they stand. The caregiver places an arm across the client's torso, which provides a good, secure something for the client to move into, and then places the other hand just on the client's shoulder to assist them to move. The client is still able to place their hands on their thighs to participate more in the transfer. There is a secure link between the client and the caregiver, but there is the option for the caregiver to disengage if necessary, rather than having 2 people fall instead of 1 if somebody becomes unstable. Disadvantages is it is harder to use a normal movement pattern when you are standing up and somebody is in front of you with their shoulder pressed against you. So it does interfere with the natural sit to stand movement. I would use the angled approach rather than the front access technique if possible. And it is a bit harder for the client to lean forward and use that natural motion. There are also limits to how much the degree of assistance can be adjusted, so it's hard to provide a very minimal assist in this position. There is also some psychosocial risk, which we need to acknowledge because there is very close contact between client and caregiver. But we would recommend that in preference to other techniques, which we are about to discuss. So controversial techniques. These are ones that, as far as we can tell, are in use, and that there may be some advantages to them, but on balance, our committee's analysis was saying that these are outweighed by the negatives and there are reasonable alternatives. So let's step through them and discuss them. The first is what we've called the zombie. So in some ways, this is the most natural thing in the world, is somebody sitting down and they reach their hands out to you and say, help me up. And so you hold their hands and pull them up. And so, I think everyone's sort of done this socially with people who are just a bit tired right now. But when we're looking at it in the case of somebody who really does need assistance standing up, it's a bit riskier. So it may give a perception of relative independence because this is a socially fairly normal way to be assisted. But it's really getting somebody up through them pulling and not reinforcing the use of normal movement patterns. They can't use their arms to assist. There's not a lot of building of function through this technique. And it also encourages the caregiver to pull someone up, to do a lot of the work. And so this is introducing high risks for both the client and the caregiver. The client is at very high risk of shoulder strain or dislocation, of elbow, wrist, and back strain, and at risk of falls as well, because there's not much supporting them as momentum is imparted to them by somebody else, and they just stand up. The caregiver is at a high risk of shoulder dislocation or strain as well, in addition to back strain. Sometimes we have heard of this being done without client agreement, and you just haul somebody up. And the committee was keen to reinforce that without client agreement, the use of this harmful technique can be considered abuse. So we do not recommend this technique. What we would recommend instead is if somebody does need some assistance to get up, at this level, the minimal assist technique will generally work, and Sheila's presented a great range of ways to scale up and down the level of assistance as necessary. So the next up is the chicken wing, which is still in fairly active use. It provides apparently fairly strong coupling between the client and the caregiver, so you can really haul somebody up using this technique, but at considerable risk to both parties. So this technique strongly reinforces dependence. There is no real way for the client to use their normal movement patterns, to use their arms to assist in the transfer, or to increase function through this. It tends to build a psychological dependence because of the lack of control that the client has when being assisted in this way. And it really does encourage the caregiver to do much of the work. For the client, there's a high risk of shoulder strain or dislocation and of damage to the brachial plexus. The caregiver is also at high risk of shoulder strain or dislocation. And if the client does lose balance and is falling, there is very little opportunity to disengage. So there's a risk of falls or a more acute back strain, especially in those cases. So the chicken wing is also not recommended. Now, if somebody does require this level of assistance, the higher level of assistance technique, we've shown a chicken wing with two caregivers. It can also be performed by one. Shouldn't be, but could be. Shouldn't be performed by anyone. The higher level of assistance by one or two caregivers, or if necessary, the front access technique, if you really can't access the side of that person, are preferred in preference to the chicken wing. Now, there may come a point at which it is physically possible to raise somebody from sitting to standing using a chicken wing, but it's really a lift. These are some of the highest risk cases for the client and the caregiver. And these are cases where if it's really a lift, equipment should be used. Any perception of greater independence in those cases is false, and equipment will help to keep the client and the caregiver much safer. Let's move to the next slide, please. So the bear hug this is also the first part of a pivot transfer. And this requires minimal space to perform, was quite a popular technique for a while. But with our analysis, we're reinforcing a move away from it for a number of reasons. One of them being that it strongly reinforces dependence. Again, having a caregiver right in front of the client or the patient makes it difficult for them to use normal movement patterns in getting up or to use their arms to assist. It also tends to promote a psychological dependence because the caregiver rather than the care recipient is really in control of the transfer. It also tends to encourage the caregiver to do much of the work. And again, there can be quite a close coupling between the two people, whether the hands are around the body as is shown here, or whether a transfer belt is used, or you just hold somebody's belt. There can be quite a tight coupling. And again, this can encourage borderline lifting. And if lifting is necessary, then it's not a manual transfer at that point, and you're moving into something that's more risky for both the caregiver and the care recipient. In terms of the actual risks, first let's acknowledge the psychosocial risk when there's very close contact between the client and the caregiver. And this risk would, of course, be exacerbated if you were looking at something like transfers in the bathroom. The caregiver is at high risk of back injury in this case. They are in a very disadvantageous position and are being encouraged to do a lot of the work. And if the client is falling, there is often very little opportunity to disengage. So this is not a technique that we would recommend. The alternatives that we would recommend are the ones that Sheila presented up front. It's possible to use these higher level of assistance techniques instead. If there's not space, we've given a couple of options for increasing space. And those will provide greater safety. Now, if a lift really is required, then we should be looking at a move to equipment, not at trying to do a manual lift. Assisting with a walker is also fairly common, assisting somebody to stand up using a walker for support. And the apparent advantage of this is that the person who is using a walker will typically have their walker with them in most places, and it's something for them to lean on as they're standing. It is dependent on access to a walker. And unfortunately, it is rather a high fall risk for the client because the walker is often not stable. And while a caregiver may be able to use a hand, a foot, whatever, to stabilize the walker temporarily, this is not actually exceptionally secure. And a client who is used to standing in this way will also stand in this way when nobody is there to stabilize the walker. So there is a greater risk. A similar or greater level of support in something to push up on can be provided by putting the hands on the thighs and pushing up on your thighs. And as Sheila was saying, you take your thighs everywhere, and they always tend to be attached to you. So there's less of a risk of two things moving in separate directions. So we are not recommending the assist with a walker, and would instead recommend, if the client's able to get up independently, pushing on the thighs or armrests. That's possible. A minimal assist can be added and scaled as necessary in this case, and can still promote independence and a much safer way of promoting independence of function. So a brief summary, and then I know I see the chat is becoming increasingly active, and we are interested in soliciting your thoughts on these. We have recommended a couple of ways of getting to edge sitting and a number of scaled approaches to assisting somebody to stand up using a similar basic technique, or two alternatives when it is difficult to access, for the caregiver to access the side of the client, when they can't stand there and step up next to them. We've discussed disadvantages of a number of techniques, and in getting to edge sitting, I'm adding a non-recommended technique is skipping this step, which I know some people do, but it really is much easier to have a successful transfer once you've gotten to edge sitting. And so we've presented some alternatives. We've called this a working webinar, and we would like your input on whether there's important stuff that we're missing, whether there are important advantages to some of the controversial techniques that are not addressed by the alternatives that we are suggesting, whether there are other techniques that you see used in practice that we should discuss or take a look at in this light. We're really interested in your thoughts on this.
Just before we go to the chat, we do want to acknowledge that we've had a lot of contributors to this work, the members of the client community of practice, plus people who have given up their time to read over the materials, and so we have their names listed here for you, and we want to highlight that this is about a multidisciplinary approach to care. So you will notice that there are individuals with all types of expertise. So I'm going to go over to the chat box and I'm going to ask Emily if maybe you can start, you and Sheila, by talking about the seatbelt. We've had a couple of comments around using a seatbelt.
So this is that, the transfer belt, you mean?
Yes, sorry, the transfer belt.
I think there's kind of mixed reviews of transfer belts. They can be useful in tight spaces. I guess the concerns about them are, in some places, have stopped using them because they found that people were hauling people up using the transfer belt.
And I see Andrea has made that comment as well. Thank you for chiming in. So with transfer belts, are you not just putting handles on a person and encouraging lifting and supporting extra weight? And that really can be a risk, because you can think, now that I've got a good hold, it's easier to hold them up more. So they do tend to encourage a greater degree of caregiver involvement, tighter coupling, I guess, with the between client and caregiver.
But they were never meant to lift people or pull them into places like you might pull your dog.
Mm-hmm. Mm-hmm.
There is a comment here, and maybe Sheila, you and Emily can address this with this restorative care approach. As much as possible, our findings are that we are not advocating for the use of tools and or equipment unless the person is physically or cognitively not able to assist. So ladies, maybe you could address the comment about, are these techniques mainly used whenever tools are not available?
I would think no.
I would think that we limited our scope in this analysis to techniques that tend to be relatively independent. Once we start looking at equipment, if we're assuming we're trying to have a no-lift environment, and I know that most healthcare organizations are trying to move in that direction, then we stopped it at the point where we would be, recommending techniques for a lift. This is very much just assisted sit to stand. And the next step after some of these is likely to be something like a sit to stand lift.
I would think that we kind of stopped. Obviously, you're going to have clients where equipment is necessary, and hopefully you're going to pick the right piece of equipment. And hopefully with maybe the idea that you can go in the opposite direction, that you can try to return to independence if that is possible. And some clients, I think, with certain diseases like MS, etc., might need a lift at a certain part of the day, but could do an assisted transfer at another part of the day. So people change over time very, very quickly. So we're not eliminating equipment by any means, but I guess I wanted to emphasize that there's a real balance, and there's things that you give up when you use equipment. You certainly contribute to deconditioning, often with equipment, and abnormal movement patterns with equipment. So if we can keep a therapeutic approach and a therapeutic transfer, that's the preferred method. But there are times, obviously, when you are going to choose the right piece of equipment.
Sheila and Emily, many of the clients in the community are challenged by the situation related to beds as opposed to chairs or commodes. Can you address how some of these techniques can be generalized to somebody who's in a bed?
Yes, I think that a bed, when we look at the ability to use the techniques that we've talked about, lie to sit is not something we've covered, but once you are sitting on the edge of the bed, and you could get, if you need to move to edge sitting using the shimmy and assisted shimmy techniques, those are available as before. And then the limitation would be that it might be very difficult for the caregiver to get to the side of the person who is sitting on the bed. This may be a case where we're looking at not being able to use the angled approach as well because the bed is present on both sides of the person, but having to use something like that front approach technique. And I think that's where that would fit in our analysis. Sheila's nodding. Do you want to?
Yeah. And I would think that obviously one of the big important factors is going to be how high is that bed? And is there a way to raise the height of the bed? And you can pray that the person isn't sleeping on a futon. But some of the techniques we use, if the bed is at some kind of a sensible height, then the caregiver is sitting beside the client on the bed and can do the minimum assist or the they can do some of the things we talked about sitting on the bed. And that's, I guess, when you haul in the OT to try to do something about the height of a bed.
Thank you. Sheila and Emily, can you see the comment here, question by Sylvia, regarding thoughts on facing the client in a parallel stance and using side weight shift to assist the patient to stand as another option walk stance? Are there any concerns with shoulder position or trunk position in walking stance?
Could we cover that in reverse order? I think if I address the concerns about the shoulder and trunk position in the walking stance, then maybe you can talk about the side. So in terms of the shoulder and trunk position, if you're providing a minimum assist, then the forces experienced by the caregiver should be quite minimal. It's really guiding somebody and providing touch prompts, very light prompts. As you move to providing greater levels of assistance with the arm that is around the client, moving further across them, there's actually also an opportunity to overlap the shoulder with the client's back. And so instead of just having all forces at a substantial lever arm going through the shoulder and having the shoulder take all of that, you can move some of the forces onto the caregiver's chest. And that can help to reduce the loads on the shoulder. And then I think the other hand, the front hand that would be supporting the client's shoulder, there shouldn't be as much force going through that. It's really a security issue, guidance and security. I think in terms of minimizing shoulder loads for the caregiver, that's also one of the reasons that it's nicer to have a hand on the client's shoulder rather than moving further down the arm, is you're also helping to keep all of the loads for both client and caregiver closer to their bodies. And then this side.
And we find people often move a little bit easier if they are pushing against some resistance. It seems to encourage the movement. So a little resistance can be very helpful.
And then the parallel stance was the other one that we didn't include in here for reasons of time.
And the parallel stance, I know there's concerns, first of all, with the lack of leverage for the caregiver, and also the torque that can occur in their back if they're using a parallel stance at the side of the client and helping them to stand. I hope that helps.
I'm going to just highlight a couple of more comments. And one is related, I think, to some research. And Emily, you might be more aware than Sheila and I if anyone has done a biomechanical comparison of the loads on the caregiver with each technique.
We looked. I have not been able to find any that's a comprehensive comparison. That was unfortunately beyond the scope of what we could do within a seed grant. So we can't add that at this point. I think it would be very interesting to see, though. I've looked. I've contacted many of the people who are likely to have done it, and I haven't seen it yet. So if you know of anything, please share.
Is anyone aware of an approved mini risk assessment that caregivers can use prior to each transfer to ensure it is physically and cognitively safe to do the transfer?
Those kinds of assessments would usually be done by a PT or an OT. So we can look into that. It's a good question. Obviously, there's a process when you're choosing a transfer. It's quite a long process for a PT or OT who is making that choice and why they are making it. So there would be some risk assessments. We can take a look at that. That's an interesting question if we could include some of those. But you're talking about a mini risk assessment. I think we're treading into dangerous waters there, especially you're saying cognitive and physical, obviously. I guess we can look at what might be an appropriate. I think just plain common sense. I think PSWs will be very quick to say, I don't think that I can use that technique today with this client. There is something not right. So I think they call their supervisors and we take a look at the status of the client. Someone has picked that, whatever they're doing.
I'm just noticing Anna R. has posted a point of care assessment for transfers from Safe Care BC. That might be of interest. I'd also point people, if you were not on our first webinar about the framework for sit-to-stand training, or for evaluating sit-to-stand training, one of the things that we are saying ought to be included is some kind of little checklist, mental checklist for support workers to run through before assisting somebody with any transfer that checks for environmental, cognitive, psychological, and physical factors. And there are a number of good versions out there, so we're not prescribing one. We've seen a lot of fine examples. We're just saying, make sure that you have something and make sure that it covers those points, because that's certainly a little check everybody should be running. And I think there was a comment here about the risk of violence, and that's also something that violence and unpredictable behavior is something that a PSW would be on the lookout for before assisting a client with anything. In terms of how it was taken into account in our analysis, when we were considering the psychological or psychosocial safety, in many cases, we're considering whether this client is likely, or whether this technique is likely to take control away from a client or impose things on them that they wouldn't like, because that is one of the things that may trigger violence or responsive behaviors.
So one of the things that this has really highlighted, and hence the reason for the SEED grant, was that there really is no standardized assessment across the board. Different organizations are using different assessment tools, and certainly if a physiotherapist is coming in to look, or an occupational therapist to look at the risk of falls, there is a standardized assessment tool that they are using for that. But in terms of evaluating the readiness for transfers, there does not appear to be something standardized. So as Emily has mentioned, our evaluative framework and the components that it includes will be very helpful for organizations to have a look at. And again, that's been put together by all of the members and the analysis done through our community of practice. And that will be posted on the CRE-MSD client patient handling community of practice very, very soon as we wrap up this SEED grant. Anne has mentioned, I think it was Anne, somebody does have, it's Lee, they do have a mobility algorithm to assist caregivers in determining an appropriate transfer method prior to the transfer. And Lee, if you're able to share that with us, if you send that to us, we will share that with the group. We have time for one last comment. Sheila, Emily, any closing comments?
Dustin has raised a very interesting point, saying some patients in the community are obese. Most days they can stand without workers lifting, but there's no contingency plan for when workers need to provide the assistance to stand. should we not have contingency plans for standing, just as we do for when a caregiver cannot make a visit? Very unsafe and not necessarily appropriate to say no in the moment of need. I think that issue of when clients are just on the borderline of a level of independence or dependence is a very risky point for support workers. And we always have to provide the guidance that if somebody's been assessed for a transfer by an OT or a PT, you're following that assessment if possible. But I think sometimes clients may be shifting day to day. And I think this is one of the cases to acknowledge that it's a good idea to provide PSWs with the tools, with the training, and respect that they do have to make in the moment decisions based on how this client is today. And I think providing them with tools and recognizing that they will need a contingency plan sometimes. So normally he can do this, but sometimes we may need to provide a greater level of assistance, and this is the next step up, I think would be quite reasonable. And in challenging cases, especially if somebody's quite heavy, maybe that's something where an OT or a PT will be necessary to help put the contingency plan in place as well. But for when that's not available, we're hoping that the training that we've recommended in our framework is providing PSWs with the tools to make good decisions themselves, as we know that they do frequently need to do in the community. So we're trying to give them more information so that they can make a good choice when the basic plan's not going to work.
It's 1 o'clock, and I want to thank everyone for joining us today. And thank you for all of you who have shared your resources with us. We will be posting this slide deck, and we will also include a posting of the resources that have been shared today through the chat box on the webinar. Please put any other comments that you have in your evaluation. We've asked you some good questions, and there's an opportunity there for you to give us some feedback to help us with this analysis and with the framework that we are putting together on behalf of the client patient handling. Thank you, and we look forward to seeing you again. Have a great day.